So we're going to focus on some side effect management and as well as some thoughts about survivorship and what I think about what I consider to be a survivor and what are some tips and some tools to being a survivor. So the principle, in my mind, the most important thing to keep in mind with toxicity management is early identification. So that's the reason why we have patients coming in to see us, is because, you know, we want to know if something is going on before things get too bad, because we can intervene, we can come up with tips and ideas and ways to manage problems before they become too bad and we have to, you know, stop and discontinue therapy. So first, we'll focus on some of the immunotherapy toxicities. And basically, I'm going to focus, like Dr. Chenier was saying, about, you know, the car analogy, you know, what happens when the car has no brakes. You know, ideally, we want the T cells to affect the tumor. But what happens when it starts to also affect the healthy tissues? And one of the problems is that sometimes it can indiscriminately affect all the organs from head to toe. Everything from the nervous system, which can include things like Guillain-Barré, encephalitis, myasthenia gravis, pituitary, which is the master organ, controls the hormones, which can affect the adrenal gland, can affect the thyroid, downstream, lungs, which can present as pneumonitis, adrenal insufficiency, pancreas, which can cause pancreatitis, can eventually cause diabetes, heart, which is myocarditis. The GI tract can be impacted. We can develop things like colitis, autoimmune hepatitis, the skin, which is a very common, that's probably the most common toxicity you encounter, dermatitis. And then, of course, a very common one is arthritis, rheumatologic toxicities. So I promised you not too many graphs, but the point of this one is simply, and again, we're focusing on melanoma, but what I want you to pay attention to is simply that, you know, when you combine more immune therapies, you're going to have more toxicity. So if you look at in the center, the nivolumab and the ipilimumab, you know, all adverse events, the toxicity is double. It's 55. When we talk about grade 3 or 4 toxicities, these are what we call very serious toxicities. Grade 3 or 4 toxicities are the toxicities that will land you in the hospital typically, right? Whereas when you look at immune toxicities by themselves, like nivolumab by itself, it's less common. So when you combine 2 toxicities, yes, you know, you're more likely to hopefully achieve those long-term toxicities, but we have to be more careful when we administer those combinations. The other question I oftentimes get that patients get worried about is, you know, when we're getting ready for that first infusion, and they're very worried about what's going to happen. You know, am I going to get really sick today? And you know, how am I going to feel tomorrow? What about that trip I had planned? I have a cruise next month. You know, what about the vacation in 2 weeks or 3 weeks? Well, you know, we can kind of predict some of these side effects and when they're going to occur. Now, granted, this slide here is focused on toxicities for ipilimumab, but you can see there's a little bit of a trajectory that we can kind of expect. So the most common toxicity that usually occurs first tends to be the rash. So usually after your first cycle, when you come in, and typically this is like if you're gonna get the nivolumab and ipilimumab, the combination, you know, when you come in after your first infusion, you'll probably notice that you're maybe having some rash, maybe some itching, and you're saying to yourself, hey, this is not so bad. This was, I can handle this. Then you come in for your second infusion. And again, this is not always, never say never, not everything's true for everybody, but, the cycle 2, oftentimes that probably is doing well. But, it's cycle 2 is what I went, and especially coming into cycle 3 is when I really remind patients, we go review the side effects again. Please call me. Don't ignore the side effects of diarrhea. It's probably not just the bad sushi. If you're having it and it's persisting, this is probably colitis, or if you're suddenly having shortness of breath, this is probably not just fatigue. And there's an important distinction that comes between just fatigue versus, fatigue. There's a situation where I worry about, there's myositis, where patients can their muscles become very weak. Now, granted, these are rare side effects, but, these are important ones to catch early. So what you're seeing here are, hypophysitis. What is that? Well, that's when I talked about the master gland in your brain. So when it's impacted, all of a sudden, some other adrenal gland slows down. So it's not producing cortisol. So you become very fatigued. You may start to have headaches. The important thing is you have to communicate that to your treating team. And same thing with PD-1 toxicities. You can see here, hypothyroid is very common. It occurs early and, throughout the treatment. Pneumonitis can also occur pretty commonly through any colitis, again, tends to occur sort of about your third cycle and beyond. And so dermatitis, that's inflammation of your skin. The top picture is the more common one that I see, is sort of this kind of diffuse red macular papular rash that we see. The one on the bottom, fortunately, is less common, but it's very serious. This is where you start to develop these blistering on your skin. We call that Stevens-Johnson syndrome, and we calculated your body surface area. That's a calculation we use on the right, what you're seeing there. This, of course, is very serious. If you have this kind of blistering, you have to come in right away into an emergency room because you can quickly become dehydrated, you can become infected. This needs emergency management. Most skin issues, though, again, can be managed with antihistamines. You can start with topical steroids, but if the itching persists, your provider can prescribe something stronger like triamcinolone. Sometimes if it's more, we usually try to manage it with topical steroids, but depending on the severity, sometimes, and like you saw in things like where it's blistering, then they will require IV steroids, or in the case of Stevens-Johnson, like something infliximab even. The next severe toxicity that you develop with immune therapies are colitis, and you can see on the CT there, you see how the colon is so inflamed, it's enlarged. That's what colitis looks like. And if you did a colonoscopy, you're also seeing these patchy appearance, and if left untreated, there's a risk of perforation, because the colon is so distended that way. So what we treat it with is, first of all, you're going to collect the stool because we want to obviously rule out other issues. It could be some infectious process going on. So you rule out Clostridium difficile, you rule out bacterial infections. But ultimately, a colonoscopy is performed and a biopsy will confirm colitis. And if that's the case, typically steroids are used. And then we actually are fortunate here at MD Anderson. We have specialists who are focused on treating this. And there are currently some clinical trials going on, but with use of steroids versus infliximab. There is some GI-focused therapies, such as vedolizumab, budesonide, and even some fecal material transplants. The next toxicity that is also can be quite debilitating is arthritis. And this was a case of a patient who had actually quite severe arthritis. You could see here the whole joint was inflamed and developed an effusion that required drainage. Fortunately, this happened while on single agent nivolumab, but he achieved a cure, but and the treatment, but again, he required low dose steroids for his to treat this. And he had joint, not just that knee, but multi joint involvement. In fact, the rheumatology team here ultimately had to treat him with an immune suppressant called tocilizumab. Myocarditis, fortunately, this is very, very rare, but it's very, very serious. This is a patient who was again treated with dual immunotherapy. She presented with a 2-week history of progressive fatigue. She didn't want to eat. She became short of breath. She came to the emergency room. They did some blood work and they noticed her troponin. Troponin is a test that we use also if a patient is having a heart attack. And you can see that that's troponin T was 1800. That's something that you might see when a patient was having a heart attack. And sure enough, they diagnosed her with something called myocarditis. This again requires specialized care, which we have developed here at MD Anderson. And again, we were able to save her, but again, it requires, recognition of this problem, and again, communication with the medical team. And that's what this graph basically points to. You can see the light blue side shows that the more common toxicities, but and which are treatable. On the darker ones, are less common, but again, they carry a much more higher fatality rate. So we're fortunate in that we have now so many different therapies. You can see in the black boxes, our toolbox has increased with both oral agents, which are VEGF TKIs, as well as immunotherapies. And now, as Dr. Tanier alluded to, these in the future, probably the addition of CAR T therapy. So, now if the immunotherapies are not, hard enough to manage, now we include these VEGF TKIs, and they have their own whole different set of side effects. But they're very oftentimes unique side effects. And so VEGF TKIs are the unique side effects that I want to focus on are going to be hypertension, and those are class effects. Diarrhea are common side effects, hand-foot syndromes, and then rash. So we'll focus on a couple key ones here. The first one is hypertension. Hypertension is quite common in all these agents, probably most common in lenvatinib. And the definition of hypertension is basically 140 or over 90 or below. That's the goal that we should try to maintain. We oftentimes will try to start patients, if they're not already on blood pressure medicines, on ACE inhibitors and ARBs, especially if their creatinine is below 2. You may want to, if a patient is already on diltiazem or verapamil, that may be a medicine you may want to talk to your provider about, because there is potential drug interactions with some of these VEGF TKIs. It's important. The most important thing that you can do, or as you can do as a provider, is to just monitor your blood pressures. And please start to do that, from day one, because what we want to know is we want to know what the trend is, and how soon is your blood pressure, going up. You don't have to check it 3-4 times a day, but as a minimum, I'd like for you to do it once, ideally twice a day. Oh, and I want to point out that there are some very helpful apps out there. There's a free app actually that available on, it's called Apple Kidney Cancer Manager, and you can collect your data that way. So I encourage patients to download that and use that as a way to collect your information and share it with us that way. The next very common, very problematic side effect is hand-foot syndrome. And as you can see, that is also a pretty common problem. It runs the gamut from everywhere from 42% to probably less common with tivozanib. And if you'll notice, like on the feet, the distribution is very much on the pressure points. You'll notice it's where the foot is putting pressure. So it's along the balls of the feet, along the heels, along the sides of the toes, and you form these calluses that become very painful. And if left untreated, these can become blistered, and then they can become infected. And it becomes so painful that it becomes difficult for patients to walk. Here's some more pictures to kind of illustrate, where those areas now look like they're also becoming infected as well. And this is distinct from the hand-foot syndrome that, patients who, like breast cancer patients who, for instance, or colon cancer patients who are on capecitabine or 5-FU develop. That hand-foot syndrome is more diffuse. This is, again, the pressure points. Again, so it's these hyperkeratotic lesions that are formed, and it can be described as burning or tingling, kind of patients, the skin becomes first dry and cracked, and especially, like I said, and it can also be on the hands as well, especially in the parts that are oftentimes used. So I had a patient once who was a weightlifter, and so the spots where he was lifting the weights was where he developed the calluses. Let's see here. So what are some tips? Well, first of all, avoid hot water. I had a well-meaning wife put, have her husband put like hot Epsom salt baths every night. Well, that unfortunately made the situation much worse, Instead, I think what's helpful is maybe using cool water and patting dry the feet. You can use ice packs, but don't put the ice pack directly on it. Just, and use it like with a towel. Avoid activities that cause the skin friction. Avoid harsh chemicals. We had one patient making margaritas at a summer festival all night, and so he was squeezing those limes all day in the sun, so that made his hands even much, much worse. You can go to podiatrists and have the calluses removed, but again, they will recur, but it can offer some comfort relief every once in a while. Using thick emollient-based creams, we tell patients to start that before the problem even occurs to hopefully prevent it. And then finally, don't even at home, don't walk barefoot. Use soft slippers and thick socks, and maybe things with wool. Once the problem occurs, though, what can we do next? Well, there's topical pain relievers that you can try. Lidocaine-based creams such as Regina Care. It might contain hyaluronic acid with HA. That can be helpful. Sometimes there's urea-based moisturizers that can help to break down the hyperkeratosis. Topical steroids have been shown to offer some help, such as clobetasol. Ultimately, we sometimes have to just hold the drug to allow for relief and then perhaps dose reduce. One of our dermatologists has been conducting some clinical trials with nitro paste, as well as topical sildenafil. So those are other thoughts. Hair and skin changes are common as well. Oftentimes patients, because of diarrhea, may have some rectal changes. So vitamin A and D ointment is recommended. Be careful with sun exposure. Your skin is much more sensitive. Nails may be more brittle, so that's something to be common. Oral mucositis can be quite a big, so practice good oral hygiene. Lanolin-based creams, especially on the lips, can be more helpful than petroleum-based because they're less occlusive, so less microbial growth. Avoid mouthwashes that contain alcohol. Avoid acidic alcohol-based mouthwashes. Tobacco should be avoided. And then use salt and soda mouthwashes. I tell patients to start doing that early and try to do it after every meal and at bedtime to help cleanse the oral mucosa. So here's an example of we have an elderly patient. She was diagnosed with metastatic kidney cancer. She had stage 3, multiple lung mets, as you can see, and she was started on a combination of cabozantinib and nivolumab. And after about 18 days of therapy, she developed debilitating fatigue. And you're asking yourself, well, what's causing the fatigue? Is it the anemia? Did she develop hypothyroidism? Is she progressing already? Is it the drug? And ultimately, it's probably all of the above. And that's the problem with fatigue. Fatigue is really a multifactorial problem. It can be a combination of things. The cancer itself, patients oftentimes already anemic, they may be deconditioned. Sometimes it's just depression, psychology may not be, maybe dehydrated. The pain medicines can add to fatigue. There may be underlying issues, maybe an infection, maybe so the problem is, almost 90% of patients undergoing chemotherapy will develop fatigue. So with survivorship, this slide really speaks to me because, everybody here is a survivor. You guys may, and what I really like about this slide is that, there's not you're not running past a banner that, it's every day, and there's potentially a gravel pit right ahead of you, but we continue on through every day. And, of course, cancer screening is one part of it, of overcoming survivorship. Is part of survivorship, but that's just one. The oncology team, we're responsible for having you come back for scans and what have you, and at some point we refer you for additional testing like colonoscopies and prostate exams and breast. But I think for me, there's a much bigger question, a much bigger picture involved with survivorship. And this is, there's the 7 healing practices of cancer. And what And it's important to think about that when we talk about survivorship. Exploring, and the first part I think is exploring what matters. I think when you're diagnosed with cancer, I think that day you never forget what that means. You never forget the day you were first told that you have cancer, or the day you were told that it has recurred. And I think it kind of forces you to sort of reevaluate what life means to you. And Dr. Abrams in integrative oncology kind of succinctly put had three important questions. What brings you joy? What are your hopes? And where does your strength come from? And when you answer those questions, it kind of forces you to detach from non-meaningful activities and give back to society in ways that are important to you. There was actually an interesting study where they looked at patients or volunteers actually, who gave back 100 hours a year. So about 2 hours of volunteer time per week, let's say. And they found that these people reported a higher mental and physical well-being than those who didn't. So this is one part of survivorship. Another important part is eating well. And I'm not going to focus on that too much because we have Dr. Daniel speaking to that. But basically, more than half of your diet should consist of fruits and vegetables, and we should avoid highly processed foods. Of course, moving more and strength training is important. We should try to make sure that we're aiming for 2.5 hours of moderate exercise per week. And of course, if we're having problems with our, because of hand-foot syndrome, making accommodations for that. And we should encourage, social support. It makes it easier to stay on track that way. Managing stress, another important part of those 7 steps of survivorship. We can't avoid stress entirely, but we can find ways, and this is individual to each of us, whether it's yoga or meditation or prayer, or journaling. Maybe it's just deep breathing. That can make a difference. Sharing love and support. Finding good social networks. They saw that patients who had a perception of higher social support actually had a reduced relative rate of death by 25%. Larger social network was 20, and even just being married decreased your death rate by 12%. It's important. I always am very encouraged when patients come to my clinic and tell me and ask me questions about, returning to their sexuality. And, I may try to keep a straight face in clinic, but inside I'm going, yes, because that means that they're feeling well enough that they're exploring this important part of their life again. So that's so important. And I encourage my patients to always, talk to their providers about these important parts of their life, right? Sleeping well, there's so much, we know that, actually, about 30% of Americans don't sleep well anyways, but that's almost that's almost twice as much with cancer patients. So adults, need to sleep about between 7 to 9 hours. I'm sure most of us are probably not meeting that. So it's important to maintain a regular bedtime and avoiding, bright lights, computers before bedtime, within a few hours of bedtime, avoiding nicotine, avoiding caffeine, finding a sleep, and enhancing your sleep environment. So a dark, quiet room. So also, finally creating a healing environment. Going out to nature can help. Exposing to the arts. Music therapy has been shown to be increase, our health. Avoiding alcohol, obviously discontinuing cigarettes, tobacco, we know that's not good for us. We live in Texas, make sure you apply sunscreen. It has SPF 30 or greater. And I want to just end with the fact that, you guys know, obviously, access to KCA. The KCA website has wonderful resources, especially when it comes to management of toxicities and side effects. So I encourage you to explore the website. Thank you.